Hello everyone and welcome to Tech to Transform, the Mantis podcast. In episode 10, Mantis PR MD Eleanor Willock met Rachel Waters, Director of Development of NHS Care at HCA Healthcare. Although Rachel ends 2021 in independent healthcare, she started it as Director of Programme Delivery in the NHS, where she led a team through the eye of the pandemic storm, securing the resources hospitals needed to deliver care to all patients, both COVID sufferers and those needing critical care. Rachel and Eleanor talk about how the NHS expanded its footprint and worked with private healthcare during COVID, and how that will continue to work in the months to come. They also discuss the differences between private partnership and privatisation for the NHS, how to lead a team in a crisis, and what would happen if Rachel had 10 minutes in an Uber with Sajid Javid. If you're new to navigating the private or public healthcare delivery landscape, take a listen.
Hi, it's me, Eleanor Willock, the MD of Mantis PR, and today I'm here with somebody that I've been wanting to talk to for our Tech to Transform podcast for a long time. I'd like to introduce you all to Rachel Waters. Rachel, thank you so much for joining us.
Thanks for having me.
The COVID pandemic is something that's really important and central to this discussion that I wanted to have for you today. So first of all, why don't you tell us a bit about the role you're in now, and then talk about very, very briefly, just explain the job you were in previously before you joined HCA.
Yeah, so it's all very much a journey of happenstance, really, and serendipity. So I have been at HCA, according to an email I got this morning from HR, 90 days, give or take. Thank you very much, it's flown. If we ignore the hell that was childcare during the summer holidays. Turns out it's a terrible time to start a new job at the beginning of the summer holidays. But anyway, especially in health, because everyone goes away for the summer. So my title at HCA is Director of Development for NHS Care, and put very crudely, my job is to develop our NHS portfolio. So historically, HCA had done very little NHS work before the COVID pandemic and before the National IS contract, which I'll talk about in a sec. But obviously through that, those partnerships were strengthened, and it's kind of a win-win at the moment for most IS providers. When I say IS, I mean independent sector providers.
Sure.
And the NHS, because private medical insurance work and overseas work, etc., is still rebuilding, and the NHS has this enormous elective recovery challenge. So it's kind of a win-win for us to be working quite closely together.
Okay. So HCA, perhaps you could explain to our listeners HCA in a nutshell.
HCA is a healthcare corporation of America. It's primarily an American company, and it's massive in the US, primarily in the South, but its headquarters are in Nashville. Hundreds of hospitals. In the UK, they have 6 hospitals, plus other sites, and a number of NHS joint ventures. So we have a joint venture with GST, with Guy's and St Thomas's, with UCLH, and with the Christie in Manchester. And we're also entering into, we're building at the moment a new site in partnership with UHB, so University Hospitals Birmingham, which is truly exciting. Our 6 sites are all London-based. We've got the Princess Grace, going to get this wrong, the Princess Grace, Harley Street Clinic, the Lister Hospital in Chelsea, the Wellington Hospital, which is next to Lord's. I am missing one, and then the Portland. And to the London Bridge Hospital, and then the Portland. So if any, you'd have heard of the Portland.
If you follow the Royal Baby game, then that's quite a
well, I always thought it was Portland, but I think they're Chel West. I think they're is it the Ludo wing or something like that? Ludo doesn't sound right, but something like that. So they're not actually us, we're more random celebrities, I think. But yeah, so historically HCA's business is PMI, British PMI, some privately owned insurance, but a lot of corporate insurance, and a lot of overseas work, particularly from the Middle East. So we do a lot of the embassies in the Middle East and their families. So. Okay,
so by that you mean that if I'm working for the Turkish embassy in the UK, and I'm unfortunate enough to need a gallbladder.
Yes, but also if you are a member of the civil service in Qatar, they'll ship you over here for your treatment rather than have it there.
Okay, right.
And so obviously that part of our work has been a little bit quiet for the last 18 months with no travel.
I can imagine. So it's been quite a recent career change for you.
Yeah.
Tell us about what you were doing before you joined HCA.
Okay, so my immediate last job was at NHS England. So I've been in the NHS, in or around the NHS, for 15, 16 years. I started on the graduate management training scheme as a general trainee. I stayed in commissioning for a while, went to EY for a while, did strategy and commissioning stuff there. And then after I'd had my kids, went back to the NHS, went to NHS England. My job when I started at NHS England, so I was there for about 2.5 years. And my original job was Director of Programme Delivery.
Yeah,
so
I think that's when we met about that time.
Yeah, it was at a Women's Leadership Network event.
Yeah, that's right.
Yeah. Where I fangirled about the Flex NHS girls because I just think they're amazing.
Yeah,
zero chill. No, I can't play it cool. So that was about standardising our transformation, the service transformation programmes, and making them more efficient, etc., and improving efficacy. Overnight in NHS England, and I'm sure in lots of parts of the NHS or local government, a lot of us got new jobs basically with COVID. So at the end of February in 2020, I've got no concept of time anymore, which I think is the same for lots of people, but
yeah,
it's just a really warm perspective. So at the end of February 2020, Simon Stevens pretty much said, go get every bed you can get because we don't know what's coming. You know, we're looking at pictures of Italy and China, and we just didn't know. And our reasonable worst case scenario wasn't looking good. So Neil Permain, who was my director there, and coincidentally, well, not coincidentally, because he was my route into NHC, was also my director on my first grad scheme placement.
Okay.
The moral being, keep your networks. Neil was asked to lead a national procurement of essentially a block contract of all the independent sector hospitals in the UK, not in the UK, in England. And because that was Neil's job, my job was to make that happen as well. So I was the director for operations of all the independent sector hospitals through COVID, through wave one.
So there was a couple of things that stood out that I wanted to ask you another question on, but I'll start with the most recent part of that. So it became your job to find as many beds that could conceivably be used for patients to send out of the NHS hospitals so that COVID patients could use those beds.
Yeah, so we didn't know at the time whether we were, because things were changing so quickly, the pace was just nuts. So if you were in that system, you'd know, you'll recognise that, but it was so quick. We didn't know if we would use that capacity for COVID patients or for well patients on elective care. And actually, in reality, what happened was we, particularly in London, stripped out a lot of equipment and a lot of staff from those facilities. So ventilators, obviously, in the short term, but also hemofiltration devices and a ton of nursing staff. And they either went into the NHS or Nightingales, etc. Elsewhere, and in London as well, we used the rest of the capacity as elective backup. So we were able to obviously ring fence those facilities as green pathways for primarily P1, P2 patients, urgent cardiac cancer surgeries, and also cancer therapies. We had a lot of sort of chemotherapy sessions set up in what used to be offices, etc., which were safe environments.
So do you mean within hospital settings or in other buildings?
Within private hospital settings, but places we were able to use that whole footprint of that facility. So we used it very differently in a lot of cases.
At one point in the press, it had talked about how things like offices and hotels might be taken over. Was that something that you were having to look at?
Yeah, I mean, I wasn't that close to that, but all sorts of conversations were happening in those early weeks. So one of the great things for me through those early weeks of COVID was that I got to know so many people across NHSEI and other parts of the organisation and DHSC that I would never normally have worked with. And there was a chap in the States, and we would speak weirdly often. People would come forward and say, do you want to use our offices? Do you want to use our fleet of limos or whatever it was? I think we had quite early on, I don't know how people made their way in, but it was just this strange network of, contacts. Someone knew someone who knew someone. Quite early on, we had someone offer us their fleet of cruise ships but it was PR wise, it wouldn't have been great given what was happening with cruise ships that week. But
no.
yeah, it was definitely, everything was talked about, and hotel space for step down or for social care. It was all on the table, and it was kind of weirdly liberating. I shouldn't say that, and I definitely didn't think it at the time, but it was quite liberating, because I don't think anybody felt particularly constrained by the normal bureaucracy. You know, really no idea was a bad idea. Yeah, no idea was a bad idea. You know, people just chucked things up, both from the public coming to us and saying, do you want this? And within, you know, policy making organisations.
Well, we as an agency, we filled in all the forms and tried to put ourselves on the roster to offer any help, not PR help specifically, any help.
We had a conversation, I think, about laptops at one point for schools, didn't we?
Yeah.
For homeschooling. Yeah, I mean, that was one of the great positives of it for me, you know, every cloud and all that. And I think you have to be a bit Pollyanna about these things, or you can go a bit mad. But yeah. Crazy.
So what was a typical day like? Where did your responsibility start and stop? Were you bringing the ideas of, we could use this space, we could make it look like this, to somebody, and they were making it work? Or
we did, I would say, across NHSEI, people settled into kind of those leadership roles fairly quickly. So Neil and I were very quickly in that pot of IS. You know, that was our gig, that was our programme. We both have consulting expertise, so I suppose we approached it quite like that. You know, what's our aim, what are we going to do, how are we going to build a team, etc. Spent a lot of time doing some kind of rapid design of a program operator model and kind of rapid thinking. And then I guess we settled into that. Other people, God, how did it work? There were calls stood up, so everyone was in a work stream, and those work streams would all meet. So for example, we'd talk to estates or equipment or vaccines. It wasn't vaccines then, but what was the big PPE, etc. And run with those things. My role specifically, so we divvied up. Neil led the commercial negotiation, and my job was to just hammer the ops thing, so basically to make it work. And it was variable really in terms of how close the relationships between the NHS and the IS were nationally. So in some areas, obviously, they'd had a very close working relationship, and some organisations, IS organisations, had done a lot of NHS work, and others like HCA were kind of out of the game really.
So how did you manage and motivate a team through that period?
So in terms of building the team, as I said, I got a new job pretty much overnight. Consequently, my deputy got a new job overnight, and she's amazing. So I think one of the kind of characteristics of good leadership or management is hiring people that are better than you, and Vicky McMillan is just so much better than me, and I was so glad she was there. So we kind of did it together really. Neil and I, again, as a throwback probably to consulting, spent quite a lot of time designing what we thought the programme model would look like, and the staffing. NHCEI had a resource hub where you could basically, again, everyone was up for grabs and everything was on the table, so you could take your job spec, which was like an A5 scribbled bit of paper in most cases, and say, what have you got that kind of meets this? And it was a weird one because you didn't really have time to dwell on that. You didn't really have time to interview people. It was more of a quick chat and a does it fit?
Did people want the job? Did people see the challenge and think, yes, result?
I would say most people wanted to do something for COVID. You know, I think very broadly speaking, most people who choose to work in the NHS probably have similar values. I definitely felt that. I didn't. Whether or not they wanted the job after a couple of months in it might be a different question. But which is just reminding me that I didn't answer your question about what a typical day looks like. Ignore that bit.
We'll go back to that. I bet that, should we just agree that there was no typical day?
There was no typical day. And when there was, it mostly just was about Jack and I my husband and I trying to split the day and manage the kids and 18-hour days work. It was mental. Anyway, so we knew what we were looking for in terms of overall skill, overall experience. I think NHSEI, possibly like a lot of NHS organisations, actually can be quite hierarchical, but I don't really work that way, and nor does Neil actually. I don't really care what band you are. I just want to work with good people who really want to get stuff done and learn and do a good job. And I was really lucky actually. I had a couple of more junior members of staff. So Harriet Wood, who was an absolute find, and my graduate actually came to work with us, Remy Goldsmith, and she's now gone on to the Accelerated Access Collaborative, and we had a really good team. We got pretty lucky, I think, because it was just a snatch and grab, really, to be perfectly honest. And actually, I suppose our team had two sides, because there was a commercial side to it, which was the other side that kind of someone in Julian Kelly's team ran. And then we had my national ops team. But actually, each of those, our team docked into an ops lead for the IS in each of the 7 regions. Didn't explain that very well. So they all interlinked. And then actually, the kind of third part of that was that the IS had a lead in each region. So someone from one of the organisations, from one of the IS providers, kind of took on that agnostic role to work with the regional operations lead and coordinate across the region. So that's how we built it.
Yeah.
Go on, do you want to ask a question before I...
Well, it must have felt relentless. I mean, it all felt relentless to most of us just living it, but trying to create change during that atmosphere. What did a win look like when you were looking to motivate people? What did a win of the week look like? Was it getting more floor space, getting more beds? Was it...
Well, no, because it wasn't getting the space, it was using the space. So It was using the capability and capacity that we procured. I think because of the way we ended up using the IS capacity that we had, a block contract actually in retrospect wasn't what we should, wasn't best suited to that. We should have had some sort of activity cost and volume type arrangement, but it's what we had for 13 weeks in the first instance. So it was more about getting people to use that locally, regionally, system-wide, locally, because otherwise it was really poor value for money. But also we couldn't really measure value for money in the same old how many hips have you done type thing, because the playing field had just totally shifted. I think a win looked like, kind of from a team's perspective, everyone's still standing. I mean, it was really relentless. They were really long days. I would say I didn't really manage a team so much as, and this sounds like I've swallowed some sort of hideous management books, but it was more about leadership than management, because NHS management can get a bit old school, kind of key skills frameworky, and it just, there was no time for that. I spent a fair bit of time when people joined the team trying to understand what they wanted from that engagement.
Yeah.
So far as we could fulfill it, there was a lot of unknowns, and there was a lot of, tell me what you're nice to have is. I can't guarantee we'll hit it, but let's see if we can do that. Most of the team had never met in person, and still haven't actually. Got a good old WhatsApp group still going, but there isn't. They still have the elusive IS team drinks hasn't actually happened yet. So I'd say it was more, building that camaraderie was a bit more of a challenge. But Vicky and I had a rule that the first, it's probably quite wasteful, but the first 10 minutes of every team meeting, and we were having them 3 times a week, was chat. It was a welfare check-in. How you doing? What's going on in your real life? Because, people were working crazy hours, crazy hard, but they also had elderly parents who were, needed shopping, dropping off, or whatever it was. So we did try and find out a bit about what was going on in people's real lives. I think the mood was probably right. As I said earlier, I think people wanted to do their bit. So I think that was on our side. And I think we really tried to recognise the value of a team because it was so relentless. So having each other's back, kind of, if someone was having a data nightmare, who could step in and help, or whatever it was. And I think from my perspective, when there were really long nights or days, they ran into each other, not asking my team to do anything that I wasn't doing was really important. So if there was, a bit of the week, I'd go over the top first. And there was a couple of points actually where I just sent gin. I literally sent gin and chocolate and eye masks. A thank you goes a long way, doesn't it? And it was fairly insignificant given how people were working, but just the small things, I guess.
I don't know about that. I mean, I think I'm with you on, certainly on the management. I mean, at Mantis, we were very lucky because we had all worked from home anyway. So we just, when we locked down, it was another day, very different in atmosphere, but we didn't have any of the tech issues or any of the communication between each other issues that a lot of teams had. You say that 10 minutes on a call 3 times a week talking personal stuff may have felt a bit wasteful. To me, it's music to my ears. I mean, I'm perhaps the sort of manager that wants to know too much about my team and is always interested in how they are, and maybe I'm slightly too nosy, I don't know. They'll probably tell me.
I'm with you. Huge oversharer.
Yeah, exactly. They're sick of my chat. I can definitely confirm that. But I feel like this is a really fascinating conversation for me because it's giving me such an insight into the other side of the NHS. From we hear about the NHS frontline a lot, but we don't hear about the I don't like the term back office in this context. It's what I can think of.
It's a funny thing.
When people are stood on their doorsteps clapping for the NHS, did you feel like they were clapping for you?
So the first week of the clapping, I was so exhausted. I think it was March. And I was so exhausted. You know that tiredness where you just don't know what to do with yourself, but you kind of want your mum because you just want to cry. So the first week really got to me, and I did weep slightly. From then on, I loathed the clapping. I don't know why. I just had a real intolerance for it. I'm from quite a clinical family, so I'm a bit of a black sheep, kind of paper pusher, but I still feel a bit guilty, feeling slightly traumatized about those first few weeks of working on this, because they were all doing actual frontline real jobs. One of them with my niece, who's a respiratory physio with no PPE, then had COVID, blue lighted into hospital, has had 8 courses of steroids since. Me moaning about 11 o'clock Teams meetings just isn't the same. But I think, there were a lot of people did a lot of stuff you didn't see.
Yeah, well, you got just as positive outcomes in terms of assisting that, though.
Yeah, I think so. I mean, I would say that to it's one of those ridiculous, probably female things, isn't it? I would say that to my team, but I just wouldn't say it to myself.
No, and you maybe wouldn't say it to a medical member of the family who was there.
Absolutely.
But I personally, I think you should have absolute permission to say that you did a fantastic thing.
I mean, I did give myself permission to use my card to go to the front of the queue in M&S. No shame.
Yeah. Absolutely. So you should. If only you could do the same for petrol at the moment, or any other.
I think they might start doing that. Because side note, I did see a bit cordoned off in Sainsbury's, and people were showing cards. So I assume they were doing some sort of
or a BP NHS loyalty card.
Yeah, or maybe they were just slipping the
card.
Dependent a tenner. I don't know.
Yeah. Police. So. You're not in the NHS anymore. You're not an NHS staff member. You've moved to, as we would say, if anybody became a journalist or vice versa, the dark side. But it's not really the dark side, is it, where you've moved to? It's the different side. So I was wondering, can you give us a really potted introduction to how private healthcare and the NHS work together?
Yes. So that has happened for a long time.
Yeah.
I don't think it's anything new. Whether people realise that or not, I'm not sure. I mean, it's worth saying that GPs are essentially private providers. They're not employed by the NHS. So when various journalists and publications start ranting about privatisation on the NHS, so worth remembering that. Side note. So it has historically happened for a long time. As long as I can think of, NHS consultant, or a lot of NHS consultants have been doing private lists, etc., often within NHS hospitals and facilities. When I joined the NHS, it was the kind of the heyday of 18 weeks, and the NHS was pumping a lot of money into independent sector treatment centres, ISTCs. So that's
the heyday of 18 weeks being 18 weeks wait for.
So the push towards achieving 18-week targets, which is still constitutional standards, but we're way off. So referral to treatment time, and then within those standards, there are obviously milestones along the way for diagnostics, etc. And then there's a 2-week cancer standard, etc. So it's not new. I think historically, the activity that's gone through the independent sector is the kind of low complexity, high volume work. So knee replacements, hip replacements, that kind of thing.
Yeah.
And a lot of people, you know, a huge proportion of the public will have experienced that if they've gone through one of those procedures in the last 20 years or so, or before. The shift, the first wave of COVID and that block contract was a real shift, because we, on a number of fronts actually, we kind of managed to solve some problems that would have otherwise taken months, if not years, to sort, and had been bubbling away for years, about trainees going from NHS organisations into independent sector theatres, people who would never have crossed that threshold, that invisible threshold to the dark side, you know, went both ways. So there's a real moment to capitalise on that, I think. And obviously within that time, as I said earlier, the IS did a lot more cancer, cardiac, complex type work. So HCA did transplants, etc. And now, obviously, the NHS has this enormous elective recovery challenge, and it's shifted again. I think there's a recognition from commissioners and providers that the NHS can't get through that backlog alone. Not just backlog, but the late presentations and the surge that's starting to come through now. I've worked with trusts in the past who didn't really want to outsource or subcontract with IS providers because they felt like it was an admission of, you know, weakness or them not being able to do it themselves. But I think those days have kind of ended, really, and a lot of trusts are prepared to do it. So the way it works, sorry, go on.
This isn't the narrative on privatising healthcare. No. So this is, I know that. I'm just making it clear that this is a completely different thing. This is the NHS and private healthcare working together to clear a backlog of operations that need to happen. So the general public will be seeing intense benefits from these partnerships. Yeah.
So what happens is generally either a CCG or integrated care system, an ICS, will commission directly from the IS. So that's more likely to happen, I would say, with that low complexity, high volume stuff. Or a trust will subcontract directly with, for example, HCA. So we're doing some work on TAVIs at the moment, so transaortic valve replacements, cardiology with Plymouth. So patients from Cornwall, they've been waiting a long time, they urgently need this surgery. We ship them up, basically. They do all the pre-work, all the pre-assessment, all the COVID swabbing, etc. in Plymouth. They come up and they have their surgery with us. One night in HDU, a couple of nights on the ward, and back to Plymouth. For the patient, the only thing that's different, apart from the length of travel, is that they have it in a really nice room. It's still, it basically is a way to get them their heart surgery much quicker than they would if they had to wait. You know, we're taking a lot of plastic work at the moment, oncoplastics for breast from a London trust. And those are, of 80 patients, 50 of them are 52-week waiters, and the other 30 are over 104-week waiters. So it's not, you know, it's not about privatisation. It's about figuring out how the IS can best support the NHS to get to where it needs to get to. And that is different for different geographical areas and also different providers. So for HCA, it doesn't make sense for us to do the low complexity, high volume stuff. We are far better set up because we've got good ITU and HDU facilities, etc., and amazing clinical capabilities because we partner with most of the London teaching hospitals. Makes sense for us to do that complex work. But there are some things that just wouldn't make commercial sense for us or the NHS for us to do. So it's about kind of finding that middle ground. And there is a mutual benefit, essentially. As private work picks up again and overseas work comes back online, the capacity that certainly we, excuse me, as a fairly niche provider have available to the NHS will constrict. So we kind of need to.
I'm not sure you'll know the answer to this because, as we've discussed many times, you're not technical. But how does patient flow work?
So actually better than you'd think, given the kind of archaic approach to sharing. So do you mean in terms of patient data?
Yeah.
And notes and stuff. So for example, we have each of our facilities, we are one HCA, but we've got 6 hospitals, a bit like one NHS and however many hospitals. Each of our sites has NHS email addresses that notes can be sent to securely, etc. What tends to happen is that the trust manage all the comms with the patient so that there isn't that confusion. They transfer the notes, the patient does that spell of the surgical spell of the episode with us. Notes go back, and it's coded through an NHS coding system. So the activity is coded as the trust, but delivered on an HCA site. Funnily enough, it's not a thing that trips us up. You would think it would be, but it's, we're governed by the same GDPR and confidentiality and Caldecott rules, etc.
That's really good to hear.
There are loads of things that could trip us up. The other week it was packed lunches for some patients going home that we hadn't thought of, but it's never the thing you think it's going to be, is it?
Well, packed lunches trip a lot of us up.
A Capri Sun and a bag of Pombears. Yeah.
I've never got on board with Capri Sun. It's just not my drink of choice. It's straw and the metallicness, and
it's just not good for anyone. It's not good for, it's squirty for kids, isn't it? Anyway.
Pombears. But have you learned the business with the ears of the juice
cartons?
Yeah,
I'm already there.
I didn't know that until
I was schooled by some patronising woman in a park, but I am there now.
Well, this is it. I needed that patronising woman in the park. My kids needed those ears. Pombears is another one as well, isn't it? You don't actually know what they taste like until you are forced to eat them by some child poking them right in your face.
I don't think I was forced. I'm just a terrible picker.
Do you go cheese and onion and salt and vinegar, or do you just go plain?
Oh no, we're a classic household. Red bags only.
Yeah, they disappoint me in their ability to break as you dip them in the hummus, though. I know that never bothers kids.
That's so true, and it's such a 2021 child problem, isn't it?
Yeah,
Can you imagine being given a bowl of hummus with your crisps in the 80s?
Yeah, hummus is definitely a parenting narrative that you wouldn't have got in 80s or 90s. I don't think I had hummus until I had kids, actually, to be fair. I am digressing, because what I really want to know is, having worked in the NHS and now working in the private sector of healthcare, what's your opinion here? How much of healthcare is healthcare and how much of it is business and logistics and operations and communications?
So I don't know if it's a spoiler to say you tipped me off about some of these questions, but
how dare you? These are completely
spoiler. I was tipped off. Doesn't mean I'm prepared in advance. Don't worry. I had half an hour.
Never been so embarrassed.
But a really good question, and I'd never really thought about it before. And I think and this might be a cop out, but I don't think you can have one without the other. So if your logistics, operational protocols and processes, and your communication processes, etc., don't work, you can't really have good healthcare. And if you have good kind of interventional healthcare, but the other stuff doesn't work, I'm not sure it really matters. I mean, it does matter from a health outcome perspective, but I don't think you can split them up. I think from a patient perspective, they would say it's healthcare, but only if the other stuff works well. Does that make sense? But if it doesn't work well, it impacts on your healthcare experience.
If you had a fantastic doctor and really vibed with them and they helped you and you had a good outcome medically, but you didn't get your bill on time and you couldn't get through to them and you had to wait 104 weeks to see them again, then the healthcare system's not done right for you, has it? It's not. It's all of those things in one.
Absolutely. I think I had a really good director of public health when I worked in Durham. His name I just don't know what it was. I can't remember at all. But she said, when explaining why she was in the job she was in, she was saying, you can have great acute care. You can go in and have a really good experience in hospital or a really good surgical outcome. But if you then go back to a house that is damp and you can't heat it, and your kids are hungry when they go to school, if they go to school, what's the impact of that? It's that kind of Maslow wraparound. I think it's a similar parallel with this. If you don't have all the, to use your phrase, back office stuff working, it kind of takes away from the healthcare interventional outcome. That makes sense. An experience.
Yeah, and I have to say that analogy from your colleague in Durham is really good, because at the moment, with the seeming, not U-turn exactly, but the disregard of what needs to happen in social care by what's going on at the moment, it's hard to see how coming out of hospital for some people is ever going to be a positive thing when they
completely. And it's not just social care, it's the universal credit stuff and just generally the widening gulf in inequalities and the fact that some kids were really left behind last year. That is the stuff now for COVID. That's the COVID stuff rather that keeps me awake. That's the stuff I worry about at 3 a.m. It's not the, do we have PPE? And are people going to get the vaccine? It's the shit, this is going to take a couple of generations at best to recover from.
Yeah. It's a scary prospect, isn't it? Did you catch COVID? Did you get it?
I think I had it really early on. So the medical director, the guy who's no, this is hard to say. I think I had it early on. The guy who is now my medical director, he's a cardiologist with whom I was working in March, thinks that's what it was that I had. It floored me. It didn't stop working, but I was extremely unwell. But I had no antibodies and I was tested whenever that was pre-vaccine. So I don't know. But then my niece, who was really, really unwell, who's still very unwell with long COVID, also had no antibodies when she was tested. So I don't know. I definitely haven't had it since testing was introduced.
Yeah.
And I have been, using the central line and all its revolting glory.
Haven't done the tube yet.
Yeah, I mean, minimal mask wearing at the moment. Yeah. I'd say about 30%, if that.
Yeah, I've been quite socially cautious, and it's definitely affected my. I'm an outgoing and a social person, but I've been really surprised by how much it's knocked my confidence socially.
Yeah, and I completely get that.
Yeah, it really, really annoys me. Really.
And also, it's both knocked a little bit of my, less so now, I guess, because I live in quite a little pocket of London that's quite sociable and largely based in a park, and not like park drinking after school, but you see people occasionally that's us, not the kids. But it's also made me really lazy. Sometimes I find the prospect of having to go out and see people completely overwhelming. I'd much rather stay at home in something elasticated. So
yes. Well, I have a friend who is always late for everything, and I once nearly bought her a T-shirt that said, "Sorry, I'm late. I didn't want to come."
I've seen that phrase and stuff.
I feel like I could probably get that now for myself, or maybe just as a Zoom background. It's been really lovely talking to you, and we're nearly at the end of our time, but I did just want to ask you my final, completely not at all premeditated question, which is, if you had 10 minutes in an Uber with the health secretary, current, not previous, what would you tell him?
I did have to write this down because I was in danger of getting really ranty. So I will try and not be ranty, but 3 things. Of course, there are 3 things, said the ex-consultant. So pathways and access, funding, and workforce. No surprise to anyone. I think first and foremost, there is a time to capitalise on the opportunities that COVID has presented in health and social care. And I am really worried that we won't do that.
Yeah.
So there's something about having the balls to do it, frankly. I mean, healthcare is a bit like the third rail of politics, but someone's going to have to at least get near to the third rail, if not touch it. And also there's a time to capitalise on public perception of the NHS. People were on their doorsteps clapping and it was all good and well, and we were staying home to save the NHS. A line that my husband's ad agency came up with, by the way.
Wow. Well
but
done.
Actually, people aren't going to be clapping when they're waiting 104 weeks for their breast reconstruction. So what can we do about public perception, kind of the public value of the NHS, and how we regard it as a free good, because it isn't a free good.
What maybe he could start with there is not agreeing with a national newspaper's campaign on GPs and video consultations.
So it's on my list. Said publication, and I'm not going to name it because I won't give it airtime. It's like when people bring Farage out on talk shows and stop giving the man a platform.
Oh, he's on next. I thought you'd like to meet.
Sorry, Nigel. We probably have very similar views. Yeah, I completely agree. Grab it by the horns. There are plenty of good comms people in government. They've got an advertising agency. So I'm pointing upstairs because my husband's in the study upstairs, working for them pretty much full time. I'm sure we could try and influence the public one way or another. But from a pathways perspective, going back to my 3 things, please start to recognise the NHS as a whole. It's not just primary care, it's not just secondary care, it has to include mental health. Remember parity of esteem that kind of came and went, that lovely notion. Community. You can't solve any of those in isolation. And I think the general public has this misconception that those things are joined up. And they're obviously very much not. So solving the whole, key to all of that, I think, is partnership with local government. From whether that's from a public health promotion perspective, or a social care perspective, or a town planning perspective, but it's so closely linked, and we know that it can work because we did it in COVID. Yeah, those local partnerships and local decision making forums were amazing, and I suppose at the heart of that for me is local decision making has to be empowered, and it can't just be lip service. Agreed. So Amanda Pritchard, almost forgot her name, that's not very helpful. Amanda Pritchard used to, before I left NHS, we were designing the operating model for the NHS, and her catchphrase was system by default. So we don't do things nationally, systems are the driver, and I am completely behind that. I think that's absolutely the right thing to do. So if they could get behind that, that would be good. Maybe pass some legislation that may or may not go through. And access, mental health primarily, and this is the GP, the paper that shall be not named debate. Digitalization is great for some people, and I'm very happy to do all my healthcare stuff with a GP on the phone, frankly, but it's not one size fits all. So let's stop letting the who run the propaganda on that. Let's ask people and let people make their own decisions,
and ask a cross section of people who've been affected. I completely agree with you.
I mean, by this point he'd probably want to get out of the cab. But funding doesn't work. There's not enough of it. I don't think it flows very well. I would love to see tariff be abolished. I don't think it encourages collaboration and partnership working. I don't think it works commercially for most people, especially knowing what I now know from the independent sector. And multi-year planning and allocation would be great, would give some freedom and flexibility to organisations to actually know what they've got coming. I mean, this year I get why we had to do H1 and H2, but it's so tricky. And then workforce, it's the only thing that solves any of this, I think, for me. So funding for training, and a hell of an effort around retention across all workforce groups.
Retention's more important than recruitment at the moment, isn't it?
Yeah,
really,
absolutely.
To all of us. And
some of that is about remuneration, and is agenda for change still the right thing, and does that still work? I don't know, but then it's bigger than that, isn't it? It's how do we foster a better work-life balance? How do we get around the fact that a lot of wards still run on goodwill? They run on your band 6 nurses staying for 30 minutes routinely, or 3 hours routinely at the end of each shift.
Well, my sadly, my stepfather has just died in hospital in Warrington, and he didn't have a mobile phone. And for example, the above and beyond there is the ward nurse using her own mobile phone so that my mum could speak to him.
That's really heartbreaking.
It is, isn't it?
But it is. That's the stuff that makes the NHS run.
Yeah.
And I think we take it for granted, and more so than ever now, probably. But it's things like childcare. 76% of the workforce is women, and childcare is not solely a woman's issue, and yet it kind of is. So how do we make it easier? How do we make it more affordable? Milton Keynes, Kate's team, and Joe Harrison's team have done some amazing work on just free parking and tea and coffee. It's not, look at what Apple and Google do. How do we learn from those? It's not even user experience, is it? But that employee experience.
Do you feel
they do so well?
From listening to your conversation, and I've really enjoyed it. And one of the reasons why I've enjoyed it is because from an outsider's perspective, clearly you've left the NHS, but the career path you've chosen next, you're still giving back to it, you're still improving it, you've not actually left, you're actually...
I haven't totally sold out.
Oh, no,
most of my day now is still working with the NHS just in a different way. It's just finding basically what I'm trying to do is find the right way for HCA to help. And yes, there is a commercial, there is a bottom line. There has to be a profit there somewhere along the line, but it's not without the positive side of it, if that makes sense. I don't know, it's such a cliche, but I love the NHS. I will always work in and around it, whether that's, in consulting or in the private sector, in the independent sector, healthcare, or even in local government. I actually don't think I'll ever go back to local government. But, that is it's such a cliche, but it's a passion. And it's just so broken at the moment. But there's a huge opportunity. It just needs someone to have the balls to do it. It's not a time for timidity. It's a time for grabbing the third rail, and to not use the NHS or social care as a political football, but to give it some money, some direction, and then leave it be, give it some stability to do what it needs to do, because it has got brilliant people and it can do it. It just needs to be empowered to.
I think that I'm going to probably book the health secretary in Uber just so that you can get in it with him and tell him all this, because that would
have a black cab. It's a bit more spacious. Don't want to sit too close.
Yeah, would you go opposite him, or would you go next to him?
Yes, because I couldn't whack my finger as effectively next to him, and I don't think I'd be able to control myself, so I'd probably have to go opposite.
You could really lean in, and
really.
And another thing,
whilst distanced. Yeah.
Okay, fair enough. Well, I have loved our conversation. It's been really nice to see you in person, and thank you very, very much for coming and joining us on Tech to Transform. And I hope we'll see you again in another season, another time. Thank you so much, Rachel.
Thanks a lot. Have a good day.
Bye.